Hi, everyone. Welcome to Module 5. So now we're really going to get into behavioral challenges uh, in supporting people around mental health and chronic health conditions, and also these major life events that people experience. And so the first four modules were really around education around certain things. Now we're going to take a deeper dive into what are the challenges around behavioral health as individuals age, and then we'll get into later modules. Well, how do we help people? Using peer support and also evidence-based practices to help people too. So, what is successful aging as an older adult? Well, if you look at the empirical literature built out by all of these scientific groups, it's aging without functional limitation. Well, that's not what aging is for everyone. Okay, so as individuals age, maybe there's mobility challenges, cognitive challenges. So when we think about aging well, it's really about aging even within those functional challenges and doing the things that you want to do, that you love to do, that are aligned with your values and goals, okay? Because functional limitations, you know, doesn't mean your life is over at that point. No, let's work around that and create a life that's aligned with your values and goals. So, why even bother working with older adults? So we know that the population of people aged 65 years or older is actually increasing. And you see this chart on the left-hand side here in 1900. There was about 12% of people aged 65 years or older. And look at all the way to 2010. Now oh, sorry, it was 2%. I'll do this one over. So why older adults? And so if you look at this chart here, the population of people aged 65 years or older has doubled from 1900 to 2010, and it's expected to double even more by 2035. And guess what? We don't have enough expertise to actually help older adults and work with them to support their mental health, physical health, and social health. There's only 5% of people who are physicians who are trained in geriatrics. It's the same actually for nursing and social work. Only 5% of people. And so here's where the power of peers, among many, many different things, we're training up a peer workforce so they can support these physicians and social workers and nurses and work as part of teams and be trained in geriatrics to help this particular population because we know we don't have services for them. So when we think about health, we take a whole health approach, okay? You cannot have good mental health without having good social health and physical health. All of these things interact with one another. Think about it. Let's say you didn't sleep well the night before, and that could be your physical health. It could impact feelings of depression or anxiety or sadness, which could then impact social interactions with people and feelings of loneliness. All of these things are interconnected with one another. And so together we'll learn how to address all of these challenges using different types of techniques. So, what makes older adults different than younger adults? This is why we need training in geriatrics, okay? One of which is frailty. As individuals age, our bone density will change, okay? There's a higher likelihood of frailty as individuals age. Frailty is associated with so many different types of comorbidities like mental or physical health challenges. It is also associated with death, too. Okay, so think about this. You have an older adult, 85 years old, and they're walking and they trip and fall. Okay? Because the bone density is different in an older adult versus younger, they have a higher likelihood of breaking a bone. And did you know if an older adult breaks a hip, their lifespan on average is only 1 year after that hip break, and that's due to frailty. So think about this. There's a 2-year-old walking that same path, and they fall. They don't have the experience of frailty. Is their bone going to break and they only have 1 year left of their lifespan? No. So this one of the reasons why older adults are different than younger adults. We have to be very aware of this. Physical health is different as well compared to a 2-year-old versus an 85-year-old. Higher likelihood of comorbid physical health conditions for individuals compared to a 2-year-old. Now, life events. We talked about this in Module 1. We all experience life events. They could be good, they could be bad. They could be stressful, could be going to school, getting your diploma, getting married, buying a house, retirement, so many different things. Now, in the early lifespan, a lot of these life events are positive, the ones I just mentioned. But as we age, higher frequency and severity of major negative life events. So things like loss of a spouse, maybe not being able, like loss of finances. Okay. It could be other things like diagnosis of a severe chronic health condition, those types of things. And by being a peer, you can share a lived experience of how you got through those challenges as well. And we'll show you some other evidence based practices. Now, the use of mental health care is different. So, older adults, we spoke about this before in module one, generally will go to primary care and talk about psychosomatic symptoms, aches and pains, and whatnot. Medical doctors, I remember only 5% are trained in geriatrics. So, what happens if an older adult is experiencing sadness and it's manifesting in a way that's creating stomach aches? And the older adult goes to the medical doctor and says, "Hey, I have this stomach ache." Is the medical doctor going to think, "Oh, that must be depression"? Or are they going to think, oh, that's like Crohn's because it's a medical symptom, right? So it's really, really easy to miss within these respective groups. That's why here's many reasons why peers are important. Younger adults, they'll go on apps, they'll get diagnosed, they're going to mental health centers and clinics. People talk about this openly. You can see commercials talking about mental health now as well. So poverty is another thing. Um, Older adults from disadvantaged racial and ethnic populations, there was not in previous generations a strong focus on planning for retirement in older age. This happened around 1966 or so with the advent of Social Security. Okay. So many older adults from racially and ethnically disadvantaged populations may still be working, may not have retirement funding, and may be more in poverty compared to younger generations of older adults like the boomers. Okay, so just some things to be aware of and how it's different. So remember how we talked about the presentation is very different among older adults and younger adults. So when we look at this chart, on the left-hand side here, we have symptoms that an older adult may go into primary care and present with. Okay. And within that, how does the primary care doctor figure out if it's a physical health condition, mental health condition, substance use, or social health? This is where you come in. So let's look at the first one. So if an older adult's experiencing hallucinations, okay, go to the primary care doctor. I am seeing a loved one that has died and they're talking to me. Okay. That hallucination, which is a visual hallucination, could actually be dehydration. It could be brain cancer. It could be vision, hearing loss. It could be Alzheimer's, Lewy body dementia, Parkinson's. It could be so many different things. Now, and if they're not trained in mental health, um, it could be, if they're not trained in mental health, they're going to go towards more of these medicalized approaches. And a person may still suffer, even though maybe they're being treated for these medical conditions. So, like, okay, well, it must be hydration for this person. So they get them hydrated. They come back and they say, I'm still experiencing these hallucinations. Well, it could also be bipolar disorder, post traumatic stress disorder, or schizophrenia, all in late life. Okay. The hallucinations, and so maybe they're still in the medical realm. It could even be substance use. Many older adults have opioid use challenges related to taking pain medication. Okay, so it actually could be withdrawal from an individual. That's why they're experiencing hallucinations. Could actually be a prescription medication side effect or an interaction. Now, finally, it could also be the loss of a loved one. People who are grieving in the early stages of grieving, they actually may see their loved one and it may be hallucination. Okay. So your role in all of this is working on teams. Okay. Or even referring out, letting people know that, hey, It could be mental health. It could be substance use. It could be social health. Let me talk to the person I'm working with and we'll have these conversations and we'll try to figure it out what exactly it is. Now, talking to someone who may be having hallucinations, you could also talk to the caregiver too, as long as you have informed consent. And you can see this list goes on and on about how these things and how do you figure out what challenge that it actually is. So take this chart with you, print it out. It's very important, and know that the people that you are working with will have a high likelihood of not being trained in this. So you can share this with them and help begin the conversations to make sure older adults are being treated for these challenges that they have. When we think of suicide um, among older adults, most of the completed suicide are older white men aged 65 years and older. And so one of the high risk factors where you would want to check in with the older adult is right after they were diagnosed with a chronic health condition. So, suicidal older adults may present to their physician with seemingly unrelated symptoms shortly before making an attempt. It's actually 3 days. Okay. So, a few things you can watch for: a mood change, especially with means for self harm. People could be purchasing self harm things to harm themselves. And so, if people are, it could prompt for a careful evaluation of suicidal ideation or suicide intent. And when working with people, what I do when we suspect ideation, I ask them, and we'll go through an evidence way of doing this: is there a presence of a plan and the means to carry that out? I'm going to show you how to ask that of individuals to make sure people are safe. Now, here some of the risk factors for suicide are bereavement, the loss of a loved one, living alone, social isolation, being a man. Now, why does it matter? Why is a man? Well, what's interesting is that women who are older, they also have suicidal ideation and attempts. However, men use more lethal means to uh, to complete a suicide versus women. Okay, so the male sex is the risk factor for completion of suicide. Being white, experiencing depression, anxiety, or substance use, having brain injuries or disorder, prolonged exposure to stress. So think about those life events. Chronic pain, life and role transition. It could be things like transitioning from working to retirement for individuals. So even though that could be a positive thing for individuals, it still promotes stress in a person's life. Access to lethal means, having a history of abuse or neglect, a family history of suicide, previous suicide attempts. Now, the highest risk is after a fatal or rapidly deteriorating medical diagnosis. Okay? So these are the things you can look at and you're going to assess with individuals. So, in an immediate crisis, if someone has attempted suicide, you do not want to leave them alone. You call 911, or if you think it's safely to do so, take the person to the nearest hospital emergency room and try to find out if they're under the influence or alcohol or drugs, or may have taken an overdose, because you can provide that to the individuals that you're taking them to, so they can help support them. And tell a family member or friend right away what's going on. Okay. And I also recommend you look at the policies within the clinic that you serve as well, to look at their procedures around this as well, around if someone has completed suicide. Now, if someone has presented with suicide ideation, and so these could be things like using phrases saying that maybe someone wants to harm themselves, and it could even be jokingly, okay? And here you want to do an assessment. Now, there's two different approaches around doing these types of assessment. If you're in a peer-run organization, I recommend you follow your policies and procedures within the peer-run organization. And other folks outside of the Medicaid or within the Medicaid system, here's an evidence-based practice you can apply. First, you need to identify the risk factors. Remember that risk factors list that we just went through? Here, You can like take this out, use the manual for this, identify the risk factors for the individual. Now, it's not all about risk. What are some of the protective factors? So, if people have a lot of risk factors, there actually could be some protective factors that help them and support them. So, talk to them about some potential protective factors. Is there somebody in the home? Do they have loved ones that support them? So, talk about things like that for for information from individuals and conduct this inquiry with an individual so you can ask questions. um, do you have feelings that you want to harm yourself, and you can ask these questions directly with individuals. What I do, because I have had to do this before, I have a paper that I just read off of. It just takes the emotion out of it for me, and so I ask those questions, and I try to get to the risk factor. Now when somebody says that they have a plan, at that point I go to the immediate risk assessment, because that is a higher level of actually working through that actual plan with individuals. So you determine that risk and then document the information for folks. So here, what do you do if someone's thinking about suicide? One of the things you can remove the lethal means from the home. And this would be in collaboration with your supervisor to ensure that you are safe in that process of doing that. Um, Also, if a friend or loved one talks or behaves in ways that makes you believe they're thinking they might attempt suicide, if you don't feel comfortable, don't try to handle the situation alone. You can get help. Bring other people in. Bring in your supervisor. Bring in people around you. Talk about it and try to figure out the next steps together. There's also national suicide prevention lifelines you can call or you can even text. And now for veterans, they also have certain lifelines as well. So here's just some evidence-based policies and procedures. But again, go towards your organization to see what their policies and procedures are as well, because you'll want to follow those, which are likely very similar.